Hello everyone, let's jump straight into it. So this talk will be about how artificial intelligence is shaping the future of healthcare. In this talk, I will try to give you a sense of what's happening in healthcare and how AI, in particular the machine learning, is used. We have this is a relatively new domain. In the sense that machine learning algorithms have been around for quite a while and they have been used very heavily in other industries, but in healthcare it's quite new. And I think first of all I should just briefly and casually start with the fact that I'm calling from Sweden and Stockholm, and we have today actually Valborg, which is a little tradition of lighting fire and stuff. So greetings to the rest of the world. You see on this map on the left side that where Sweden is in Europe and Northern Europe. It's actually still very cold here, but soon hopefully it will be better weather. And also I think it's fair, I don't know sometimes how much you know about the speakers. I think it's often useful to see who I am, and I will also ask you in a minute a little bit about who you are, because I think it is actually quite good to have a little bit of a dialogue later on in particular. I've been working in AI and particularly healthcare for the last 20 years. I have a PhD in artificial intelligence from Monash University in Australia and Faculty of Medicine and Information Technology, and I have degrees in psychology, theoretical computer science, and software engineering. That's sort of my basis in this field. I'm currently the founding director of the Nordic Artificial Intelligence Institute, the CEO of HealthiHabits, and also an adjunct associate professor and researcher at UNSW in Australia and the Karolinska Institute here in Sweden. And then I worked before at leading IT companies in their research and innovation fields, leading healthcare analytics and services, for example, at British Telecom and IBM Research and Hewlett-Packard. That's a little bit about me. I mean, while I'm talking, it would be great if you guys could write down on the right side of the chat box a little bit where you're from. So when I later look at the questions, it's definitely very interesting for me to know in which university you're from, or company or government organization, what type of AI you're working with, what's your interest in health in particular, because this talk will be about health. Yes, so I think the talk is roughly structured 4 areas: preliminaries and context. I think it's always useful to see how we are operating here in the Nordics with healthcare. Healthcare is sort of a bit of a special beast, particularly for developers and data scientists. And then I will talk a little bit about what AI means and how it connects to health, and actually what health is. There's not always a complete definition about that. And then I will talk about one application area, which is which we used here in the Nordics, and then a few more aspects about the future of AI in health, because I think this is a very big field. So I think I will say a few words about the institute that I'm from and HealthiHabits and the AI ecosystem in the Nordics. Briefly, we have actually recently formed a non-profit organization with experts that have a very strong track record in AI and are dedicated to digitize the era of healthcare, medicine, and life science, which is currently in a big change. And we have already been advising a number of governments, even startups and different IT companies. And you're more than happy to sort of find us here on the Twitter or the website. Okay, then HealthiHabits is the organization I'm working. That's a startup really, and we're building here an AI platform that enables people with a chronic condition to connect with each other. We're using their similarity analytics and similarity machine learning, which is in part based on CDR, from the 80s and 90s. That's where it started, and we have essentially using it now for the personalization and providing people with a chronic condition instant support. And you will also be able to find us here on these websites. No, just use a different pointer here quickly. Yes, and we are embedded in a world-class AI ecosystem here. I don't know where you guys are from. I will read in the chat later on, but not only do we have numerous companies that are working in AI here, which are also active internationally, for example, AI Fluidalytics and Koala, live. Other companies which are really global and very successful, like Spotify, Klarna, and so on, which are sitting here in Stockholm, they are using AI very heavily. It's really fantastic. There's interaction between these different industries. Stockholm and Sweden is not so large in terms of population, but in terms of AI and engineering capacity, it's very, very heavy, and it's fantastic. And I meet many people from Spotify and these companies a lot to change ideas of how AI and machine learning can be used in healthcare. And then briefly, it is the reason I mention this is that the people that I work with and that do machine learning and data science, many of them have a medical background. They're medical doctors, and the thinking there is a little different. There's often a very heavy semantic background, and these 8 to 10 years of pure education that doctors bring into data science, which is different to, let's say, music recommendation or other areas. And the UNSW sits in Australia. The Karolinska Institute is the medical university that decides on the Nobel Prize every year. And I really hope that in the future we will also have machine learning experts and AI experts getting a Nobel Prize, really, in this area, because I think it will make a huge difference to healthcare. So this is on top. I think some of you guys have seen this, so I won't talk about it, but it's essentially just like many startups are now trying to, in AI and machine learning, are changing the healthcare ecosystem, really. You see some of these areas, risk analytics and data analytics, but more used in the US perhaps than in Europe due to changes of Obamacare. Then you have imaging and diagnostics and other areas. So also worth mentioning, next year we have in Stockholm the ICHGAI 2018, which is the largest conference on AI, joint conference. And if you come over to Stockholm, let us know. It will be great to have you here. So that's about the ecosystem in the Nordics. AI in health. So, I mean, I don't have to talk to you much about AI. I guess most of you are knowledgeable about it, but I think it is worth noting that in AI, there are obviously different areas look heavier or deeper into a certain type of AI technology and algorithms and development. So if you look at music, it's often recommendation, for example. If you look at finance and fintech, it's like, it's a big Hadoop systems that are used. In healthcare, it is in part around the machine learning, and obviously this big data buzz is very important. In part also robotics. Can't really see that here on the bottom, I just realized. Yes, so those are the areas that are really quite important in healthcare. More importantly, what's healthcare? And according to the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. And the healthcare system consists of many aspects, organizations, people, actions, and whose primary interest is to promote, restore, and maintain health. It is very complex, and most of us have actually an understanding of healthcare as being the healthcare system where we go to the clinic or we go to the doctor. It is much richer than that. It also includes your family. It starts including now healthcare providers and food, companies that are delivering food and retail outlets and so on and so on. One of the biggest issues is really that the aging and the lifestyle has an enormous burden. It is up to 80–90% of our healthcare costs, which are constantly increasing. We get older, that's one big issue, but also the lifestyle, the food that we have, the stress that we are exposed to, really makes the system as it is today very unsustainable. Yes, so there is a huge potential. You see here, it's really what I try to illustrate is that the data and the tech and the AI in its capabilities and what it can do is increasing rapidly every year. At the same time, the healthcare demands are not met in society. And when such a situation occurs, you really see there are huge opportunities from an entrepreneurial point of view and from a research point of view to move the system, to move from this old system of handwritten notes to a system where things are highly digitized and connected. And You will see that later in the project, how we try to do that. So what I really, when I have discussions with CEOs of hospitals or government organizations, the benefits of AI really lie in dealing with these tedious complexities, and it can do very fast. So once you find a way with your machine learning to make a change, it is something where you are able to personalize the information, not only to patients, for example, and to users, but also to doctors, which might benefit from usually very complex information that they cannot always review. It could be data and medical results from a patient that has been collected over the last 5, 10, 20 years, and to see patterns in this type of data. And once you have found a way of personalizing this information based on the information that you have available and the data connections that are available, you're able to actually scale this very dramatically. And that means you can scale it across patients, you can scale it across doctors, or you can scale it across clinics. And this is really a very important aspect in healthcare. In healthcare, you also have roughly, I divide them sort of in 2 areas. One are these emerging areas, some would then call it digital health, digital medicine, digital therapeutics, diagnosis, and so on, wearables. Many of these are not part of the public healthcare system or the official healthcare system or the traditional healthcare system. These are more listed here on the bottom. We have clinics in the US, for example, Kaiser Permanente, or in Germany, you have Schönherr clinics, and so on. The life science industry, payers, regulatory bodies, and so on. And those are the areas where you do have a lot of tedious complexities which you need to deal with. And doctors will very much appreciate to have those complexities removed from their daily lives, which means in practice that you have less chances to make errors. You can deliver much more accurate care, much more sustainably to individual patients. And these are things that are important within the healthcare setting. I will talk a little bit deeper now about a specific project in Sweden. And it shows you, it gives you a bit of a sense. I had to make a choice if I will talk about projects where we used very, very heavy state-of-the-art machine learning and data science algorithms, of which I could have talked a lot about, its mathematical complexities and how we developed it and what type of systems we used and how many gigabytes we had. But in healthcare, often it has a lot to do with the deep semantic richness of the data. And how it's interpreted, what it means for people that have a certain health condition, and so on. So I chose an example here, which we worked on in the Nordics here for many years, which is called Sveos. And I think it is very unique. And I think that's, since we have a global audience, it is useful to really look at this and show you what the challenges are in this field, what results we were able to obtain. So, I mean, the Sveos project essentially has a very unique database. So the Nordic countries have a very special environment. So it includes Sweden, Denmark, and Norway, and also Finland and Iceland. There's something called the personal number. That is a number that is really used across all companies and government organizations. It's used in many situations. And that means that you can actually, the different data sources you can theoretically, and they are to a huge extent all connected with each other. It was a big decision made by the Swedes and other Nordic countries back in the 60s and 50s that such a thing would be done. And it means that you are essentially able to see what people are doing, to have a bit more of a transparency. So it's a trust in the government. Of course, projects like the one that I will show you in a minute are very heavily protected. So it's not like we actually can, broadcast these results or talk to people or share the very detailed information to others and so on. But here it is worth noting that before any of these machine learning developments in health take place, it requires often, if not always, to have deep experts involved. Medical doctors that studied for 8 to 10 years. And in our case, we had essentially panels, nationally and international panels with the leading surgeons and experts in different areas, such as diabetes or certain surgeries. And there's a huge semantic complexity in this type of data, which we need to make part of our data models. And we focus here on one thing. I want you to focus perhaps on one part of this project. The reason, the purpose of this project was really that there are unwarranted variations in health outcomes in practically every system in the world. And what does it mean? So variation means you go with a particular condition to one doctor in one clinic, and essentially the same type, another person with the same condition would go to another doctor in another clinic, and overall the outcomes are different. That should not happen, right? I mean, you should receive about the same care in any environment. And so in some cases it can be warranted, which means that, for example, certain university hospitals have training, they train doctors, they train surgeons, and then sometimes operation times are longer, or there are other reasons which just you have no control over. It's deliberately done. But sometimes they're also unwarranted, which means that you don't really know why in one clinic people have far more complications of an outcome than in other clinics. And that is an opportunity for the healthcare system to become better. So imagine essentially, ultimately, a way where you have healthcare clinics and doctors and so on, which are able to deliver the same type of care with the same quality and the same resource use also, so that you achieve the same outcomes. So it's really an opportunity here to enable healthcare, every stakeholder in the healthcare system, to monitor and act in real time on patients that come in and make changes as they are needed. So the SWEDES project really looks at, it involved almost all states in Sweden. We had overall 8 patient groups, which we looked at: spine, stroke, diabetes, and so on. Here in this example, we look at obesity. And for that particular group, we had up to 27,128 patients that we looked at over a period of from 2007 to 2013. The data sets that we used for our analysis varied a little bit. As you know, if you have data science experience, there's usually certain data that doesn't qualify to be analyzed, and so it varied a little bit with the population. And I must apologize, some of this is in Swedish, but I think, I just saw there was one guy from Berlin, so he might be able to read some of that. But I will summarize this quickly for you. So the uniqueness here lies in this: there's no other country other than the ones in the Nordics that allow you to connect across all these different databases. And I give you a sense roughly what these are. It's these systems that are essentially journal systems. So when you go to a doctor, he makes notes. They are part of the PASS and the PAR registries. It is a lot also to do with your, with the medication you take, and what tests you take, and all the notes from the doctors across the board. That's one. Then we have quality registries, which are very, very important. There's probably, again, only Sweden and some other countries which have close to a complete record of most patients from a very, very detailed point of view. So in bariatric surgery, for people that are obese, I must say, maybe it's not everyone is familiar with that, we know exactly what happened before, what complications occurred, how much weight people have lost after these operations, and so on and so on. And this is essentially entered by surgeons. It's a commitment by surgeons in Sweden to enter this type of information. It's very complete, and it's used for research purposes. Then we have the Försäkringskassan, so they note stuff like, for example, if you have been sick, your sick days. Then we have information about, what medication you take, which is the Läkemedelsregister, when you were born, when you are dead, with whom you're living together, how much you're earning, and so on and so on. So there's a whole bunch of this information. For the research purpose that we had, it is a very very, very rich database, and there's practically no other country that can put this information together. I'll give you a little sense of some of the complexities that we had to deal with. What you see here on the left is essentially and or it starts on the right. So this is really what happens. It's essentially an assessment at the beginning of the when a patient comes to the doctor. They assess whether or not the patient qualifies for this for an operation. Then you have essentially a decision to be made for the surgery, and then you have visits. The operation occurs, and then you essentially follow up over a period of 1 or 2 years, sometimes often longer. Depends what happens exactly. And so sort of a simplified scheme that happens here on the right. For us, from a data point perspective, we had meetings with experts over 1 or 2 years, specifying, for example, when precisely this operation took place. It's not that trivial, it could be precisely on the day when the operation occurs, or it could be the time when you actually enter the hospital. And you may need 1 or 2 days or longer sometimes to actually prepare for this operation. And those specifications we used as part of our data model. And then some of you might be familiar with the term case mix variables. So from a mathematical point of view, it means essentially you can run regression models, and these are the co-founders, which enable you to, in this case, qualify the results that you're getting. So to put it simple, so what you see here is essentially different factors like age, your degree of education, if you're married or not, if you're male or female, etc., which you see here on the right. The profile, whether you have other comorbidities, for example, diabetes or depression or other things. There's a whole bunch of others here. And those values, they tell you something about the patients at the time of arrival at the clinic. So it wouldn't be fair to compare the outcomes of treatments by certain doctors and clinics and different states in the country if you do not take into account the background of those patients that come in. So if you happen to have a very old population of patients, then obviously you need to adjust for that type of population. Right? It would not be fair to compare a group of patients that come in there on average 60 years old and they do such an operation, which actually seldom happens, or you have a group of 25-year-olds that on average have this condition. And then you compare the outcomes. So it's more likely that people that are then older, are more likely to have, for example, complications and so on. So this is what you see here. Then the health outcomes, it's essentially we divided this into 2 sections. So we have the health outcomes, which is, for example, the very first one you see here is mortality. So whether or not you die, which is, a very small chance, but of course it happens, which is within 30 days, 36, 1 year and 2 years. There's a number of other measures, and we will go a little bit deeper about the results later. And here also these potentially avoidable complications. That's how we call them, which means situations like when you get infections and so on and so on. So, one is to obviously improve the health outcomes, and the other one is to reduce complications. These are the 2 things. But all this wouldn't be complete if you don't look at the resource use. Because, obviously if you throw a lot of resources at a situation or a problem, then you also have, you have better outcomes. But, these are essentially the resources, which are things such as, how many visits you had before, how many sick days you used, and so on and so on. So, and then in terms of machine learning, we used quite the, let's say, I would call it from a machine learning point of view and from an AI point of view, possibly really the 1.0, the 0.1, of machine learning. The simplest are really regression models that we are using, with all these co-founders and different estimations of, estimation methods, such as the OLS, approach. And so, and now I will also give you a quick idea about some of the results that we had. You will see in the next slide, essentially, the actual observed outcome for particular healthcare providers, which you see here on the bottom. And those are the case mix adjusted outcomes here, the green bar, the right bar. which means that is what it should be according to these adjustments that we did of the population. And on the right side, we use essentially confidence intervals to ensure to see whether we have a significant, change or not. What you see is when you take the entire population with different states, so this is actually by state in Sweden, that overall you have actually a reduction here. In this case, it's diabetes type 2, that once this bariatric surgery has been done, many of the people that had diabetes type 2 at the time of operation, which is a very severe disease, which can cause blindness and death and so on, often the comorbidity has gone down by 70% after 2 years, which is pretty significant. What you then see here on the blue bar is essentially what you observe today. In some cases, you see already the variations, right? 81, 83, 64, and so on. So you see that variation, but that might be granted if the case mix is different. Now, in this case here, we see that the case mix, suggests that in this case, it's actually higher than what you would expect. And for this particular clinic, it means that they are performing better than how it's expected, given their case mix, which is good. We have also serious complications. Here you see a much bigger variability, which you don't want to have really. The case mix variations, if you look at the green bars here, is pretty much about the same across the board. So you would expect complications to be about the same, but the real values are actually much higher and lower by percentage than they should be. And these are the sick days of individuals. You can see that they are different states and the different clinics where the patients have significantly higher sick days than in other cases, but also it is warranted. So for example here, or like at least it's not as high as you would expect. And on this case here, you see that you have the green bar being a little lower, which means it's probably a little bit higher than it should have been. Operation times vary largely too. And in this case, this is sort of a to be expected situation in some cases. If certain hospitals, hospital clinics have a higher operation time, then that is for training purposes. But even for this, variations are not expected to be higher. All right, I'm just looking at the time, and I believe I have about 1 or 2 minutes. So I think I'll just briefly mention a few things and what I wanted to finish with what I started with, which is so a few more words about the future of healthcare, brands and technology. One of the reasons why we created the non-profit organization, the Nordic AI Institute, is to actually make sure that we help CEOs and people in the non-AI domain, in the non-machine learning domain, to understand the difference between brands, technology, and the scientific algorithms that are behind some of those proposals made by industry players. And it is very, very important for us in the AI community to have that expertise and to make sure that we enable our customers and bosses, that they understand how powerful AI is, but no more. So we wouldn't want to be in a hype situation where we promise things that can't be held. And it means really that, at best, and that's a bad situation still, a CEO of a clinic would not understand what's possible for his organization. But at worst, you often be dazzled by the marketing buzzwords and brands and make wrong long-term decisions. So this is something that we really, I think, need to focus on. It's one of the reasons why we have some of these, some of these projects and institutes that we have been building here. So I may skip that slide. It's essentially really that there is a strong commitment towards the potential of AI. The idea that you can personalize and that you can essentially scale this approach with the enormous complexity that is about to come is understood by many. Kaiser Permanente is one example. And I think I will say, I think it's the second last slide. Most of you know Andrew Nunn, and he suggested to actually have a chief AI officer in any organization, comparing it to the need of having someone that knows electricity in detail 100 years ago, because of all these complexities. And I've listened to a talk yesterday and today in the morning, I think, where some other speakers suggested a similar thing. So we need to really understand this well to make sure that we don't use non-trivial machine learning algorithms and essentially expand what we have done. So you saw in our example that we use reasonably simple machine learning there, if you want to call it that even, you know, and we have an enormous potential. The amount of nuggets that is in this data is huge, but we need the people to understand what these nuggets are. All right, good. So I'm glad then went through this. If there are any questions, please let me know. I will change back to the screen for me. Some questions. So, yeah, no worries. So there were some practical questions. For example, the conference in Melbourne. Yes, it is the International Joint Conference on Artificial Intelligence in Melbourne. I will also be there. The itch guy, if you haven't heard of it, is a very large scientific company, conference, the oldest in AI. So one of the oldest anyway in AI, that really puts together different players across the board: robotics, machine learning, multi-agent systems, and so that's happening in August. So look it up. It's called itch guy. I just typed in here, and you will see that. That's a very interesting one. It's a lot of science. It's a very science-heavy conference, but we have obviously a lot of big scientific players. Companies that are sponsoring the event. And how are these health companies working together to get the best solutions more rapidly? By these health companies, you mean like? So I'm assuming that you mean by health companies, you know, for example, the clinics, and then you have different providers that do machine learning, or I guess, or do you mean health companies in the healthcare sector? So, for example, pharmaceutical companies and the government and so on. Yeah, that's a good question. I think, let me see now if you answered it. Pharma companies more, but in general. Okay, yeah, no, that's a good point. We actually have a number of discussions here. Pharmaceutical companies are now in an era where they need to change their business model, and they are swimming in data, but it's definitely not their core business. So the question about how to most effectively work together for a pharmaceutical company, I would almost like to take that offline. That's going to take a little bit of time, but I think it's, as I said before, in-house capabilities of AI and machine learning is very important to have an informed discussion with other players in this field. If you're swimming in data and you really need to connect to other players, like non-traditional players, you know, then I think you need to have in-house competency. Otherwise, the discussions become, and that's definitely something that we see here a lot too. You know, the discussions become not very deep, and so it takes a lot of education time. But I'm happy to take this offline too. Let's see now. Often lagging behind other digital fields due to privacy. Yes, data privacy. Ekaterina, she asked a question. That's right. We connected earlier, right? Yes, that's true. That's true. There's a lot of red tape and data privacy, but it depends how you structure it. You can go two ways. You have a digital health company, and you actually look at privacy data, which is not health data, and it's not within the healthcare system. And then you follow the same rules that any other player in the field, any other industry player. Or it becomes a health. I'm simplifying a little bit. Or it becomes a health system, and you're part of the healthcare system. And then you need to definitely go down a long road of 5 to 10 years, getting FDA approvals, medtech device, approvals, etc., etc. So it depends really where you want to hit. That's the short answer there. And then how do we drive the incentives for pointing CAIOs at large institutions? Well, the incentive lies in the business model, really. I think ultimately the CEO's responsibility is to see which capability and which competency does he need to execute on the business model accurately well. And if the business model is not working, which it doesn't in many healthcare companies, such as pharmaceutical companies today, where the government asks for essentially more value, and more value can only be created by looking at the vast amount of data and by developing better and smarter services, then that is starting to become an understanding. And some healthcare players and pharmaceutical companies are acting on that. So they do actually support here in the Nordics, and in Berlin, I know they start to really engage with AI companies to see what they can do. And ultimately, I think, like with many organizations, they will see the need to have absolute experts in that area. Just as if you were the president of a country and you see a big need of having an expert in a certain area, then you make a minister post. So, but it's, you know, yeah. What other industries could learn from these ways healthcare is becoming digitized. I think actually it's almost the other way around. Like most other industries have become quite digitized. Health is a little bit behind. And it does take time for healthcare due to some of the reasons that I mentioned in the presentation, which is that, you know, you need to, there's a huge tradition behind healthcare and medicine. It's one of the oldest industries, if you like, in the world, caring for someone else. And it's not something you would or could just change overnight. Money is a little younger, you know, the whole fintech sector. Other areas are a little bit more open, logistics, for example, or music, and so on. So it's more almost the other way around sometimes. Media also, you know, like when in the 2000, you know, Fraunhofer Institute developed the MP3 media. That's how Spotify and the companies back in the time changed from CDs to MP3, you know. So, yes. So I try to very briefly go through some of your questions, and if I have not answered them completely, or you have questions after the talk, then let me know. You can contact me, and I'm happy to answer your questions. Excellent. I'm just looking a bit at your background. Paris, London, Israel, MIT, Hamburg. Okay, fantastic. Quite a bunch here. Great. So yeah, thank you, Amalia. Thank you very much. I was very happy to give a talk.